सूर्य अमीनो एसिड सूर्य અને પોટેશિયમ રેશિયો ચેક કરવાનું ડૉક્ટર કાર્ડિયોમાં જોવાનું અને અંદર કેલેરિયાના ફીચર્સ જોવા મળે છે અને સૂર્ય chest radiography measures the pulmonary edema and pleural effusion. Others are RPC and systemic witness glomerular process. Many further investigation kidney biopsy may be necessary post-renal acute renal failure. The renal imaging by plain abdominal X-ray and ultrasonography may be used for post-renal plasma. Fractional excretion of sodium, the ratio of sodium clearance to creatinine clearance increase the reliability of this index. However, it may remain low in some renal diseases. Complications of acute kidney injury. First, the type of acute kidney injury when there is a case of cause having a pre-renal cause, there is normal urine finding, or maybe having a hyaline cyst. In intrarenal cases, the tubular cell injury that having a muddy brown granular meticular casts મળે છે. Interstitial nephritisની અંદર pyruvia, hematuria, proteinuria, glomerular and epithelial blast, eosinophils. Glomerular nephritisની અંદર hematuria, marked proteinuria, reticulocyte, granulocyte. Vascular disorders normal hematuria, mild proteinuria. Post-renal cases ની અંદર જોવા મળશે normal of hematuria, urine, granular cast અને pyruvia. Complications of acute kidney injury. The metabolic in case of metabolic complications are हमारे साथ श्री रघुनाथ तो किस बात की चिंता, हमारे साथ श्री रघुनाथ तो किस complications of kidney complications are hyperkalemia, hypocalcemia and hypocalcemia, hyperphosphatemia, metabolic acidosis. Cardiovascular complications are cardiac arrhythmias, pulmonary edema, pericarditis, pericardial effusion. Gastrointestinal complications are control gastrointestinal hemorrhage. Neurological complaints are encephalopathy, neuropathy, seizures. Hematological complications are anemia, bleeding, platelet dysfunction. Miscellaneous complications are infections, others like pneumonia, UTI, and septicemia. Urinary abnormality, specific gravity raise. Okay, urinous molarity. Management. General measure and management of complication. Fluid balance. Advice to restrict the fluid intake. પહેલાં તો fluid intake ઓછો કરવાનો છે, ઓલરેડી ત્યાં ઇડીમાં થયેલો છે. સો પહેલાં તો fluid intake ઓછો કરો. Amount of the fluid to be given depend upon the degree of edema and fluid loss through the urine, gastrointestinal tract and skin. Usually intake restricted to about 400 ml per day, in addition to the above mentioned fluid losses. Sodium balance. Sodium is restricted to avoid volume expansion and overhydration. Hyponatremia is common and is usually due to excessive fluid administration. Hyponatremia may occur occasionally due to excessive administration of sodium bicarbonate for correction of acidosis. Yes. Potassium balance. Hyperkalemia is leading cause of death in acute renal failure treatment is discussed. Okay, దాని અંદર calcium chloride, calcium gluconate, dextrose, sodium bicarbonate, magnesium sulfate, normal saline અને એટલા આ વસ્તુ આપવાનું. પછી એસિડ બેઝ બેલેન્સની અંદર ઇન મોસ્ટ પેશન્ટ એસિડોસિસ ઇઝ અ મોડરેટ acidosis is of a moderate degree and does not require treatment. However, in advanced cases, the intravenous sodium bicarbonate may be necessary. Acidosis is if accompanied by the severe hyperkalemia. The fluid overload is best treated by dialysis. Calcium phosphorus balance, both hypocalcemia and hypercalcemia are observed in the maintenance phase of ARF and are not serious clinical problem. The phosphate retention occurs in a patient can be controlled with aluminum hydroxide, lanthanum carbonate, sevelamer calcium acetate or calcium carbonate. Dietની અંદર restrict dietary proteins to about 40 grams per day, suppress the endogenous protein catabolism and minimum level by giving such energy as possible in form of carbohydrates and fat. Patient treated by blood purification techniques are given 70 grams or more protein per day. Hypercatabolic patients may need higher nitrogen intake to prevent negative nitrogen balance. Restrict the salt intake. Vitamin supplements are usually necessary. Systemic complications of ARF, infections and gastrointestinal bleeding are two important complications. Infectious complications include pulmonary, urinary and wound infections. Infectious should be treated promptly by appropriate antibiotics. Gastrointestinal bleeding may prove fatal and treated by proton pump inhibitors and gastroprotective agents. Qualitative platelet dysfunction may result in hemorrhagic dialysis. Use of drug. Great care is necessary in the use of drug and nephrotoxic drugs should be avoided. Treatment of the underlying cause of AKI. Identify the treatment. શું કરવાનું? Identify the cause. renal છે post renal છે. cause સિમ્પ્લાય કરવાનો. ઇન્વેસ્ટિગેશન, અલ્ટ્રાસાઉન્ડ, renal biopsy, corrective if possible. સ્પેસિફિક થેરાપીની અંદર શું છે? નો સ્પેસિફિક ટ્રીટમેન્ટ ફોર acute tubular necrosis માટે કોઈ નથી than restoring the other than restoring the perfusion. Increasing kidney disease may require specific therapy. There are example in immunosuppressant drugs such as corticosteroids, cyclophosphamide, in some cases rapidly progressive glomerulonephritis. Post-renal obstruction may require urgent relief of obstruction. Once the blood chemistry returns to normal, the underlying cause should be treated whenever possible. Drug-induced acute tubular intestinal nephritis usually occur after stopping the offending drug, but sometimes short course of steroids may be helpful. If conservative measures fail, dialysis and hemofiltration may be necessary. The techniques to purify blood or remove excessive fluid may indicate dialysis and hemofiltration in ARF are listed. Fluid overload હોય, refractory diuretics and refractory pulmonary edema, metabolic acidosis, resistant hyperkalemia હોય જે calcium gluconate, calcium chloride, dextrose, sodium bicarbonate બધું આપતા સોલ્વ નથી થતો. પછી કોમ્પ્લિકેશન્સ ઓફ યુરેમિયા હોય, પ્લાઝમા યુરિયા વધી ગયું હોય, એન્ડ સ્ટેજ renal disease હોય, સિવિયર બાયોકેમિકલ derangement હોય, in absence of symptoms, removal of drug causing the acute renal failure, severe hypophosphatemia, tumor lysis syndrome, anuria for more than 12 hours. Okay. Cause of death. Most common cause of death in AF are hyperkalemia, pulmonary edema, followed by the infection and uremia.